And now we open this floor to anything you like, comments, questions. Okay, Dr. Jorge, do you want to introduce yourself, please?
Hello.
Las nenas se me duermen, las nenas se me duermen.
Gracias. Buenos días. Buenas tardes. Soy el doctor Jorge Vázquez de Morelia.
Hello, I'm Dr. Jorge Vázquez from Morelia, Mexico. When you talk about not using them in immunodepressed patients, who are you talking about? Cellular newborns are physiologically immunodepressed, undernourished patients are immunocompromised. So who yes and who cannot receive them? You talk about sometimes yes, sometimes no. So I think we ought to have studies on what kind of immunocompromised patients, oncological patients who before receiving chemotherapy are not immunocompromised, but if I give them, this might prevent neutropenic colitis, for instance. Well, that is like pinning the bell on the cow, on the cat. Nobody wants to take the risk. Carrying out these works on patients with an immunological risk of severe complications through the use of a drug, as we heard this morning, is hard. No lab might want to support such a work in order to evaluate that there is a risk of causing this disease, because the risk exists. And it's also important to highlight that there is no homogeneity in the case in this evaluation of immunosuppression in this work. So essentially, there can be no recommendation because there are no parameters, no strict parameters that can tell us that a patient or that a group of patients have X type of immunosuppression or X level of immunosuppression that might allow or recommend the use of a drug and diminish the risk of a disease and even increase the risk of producing another. I don't know if any of you want to add something to this. Short questions, please, Dr. Warner. Short answers as well, so that we might exploit our time. In the case that we quoted, beneficial microbes, what we did was to collect from literature, from the essays that were published already when probiotics had been used in a control study with a placebo group, and patients whom we defined as immunocompromised, because they were patients with AIDS, because they were patients who were receiving an immunosuppressor, including acetopin or corticosteroids or anti-TNF biologicals, or patients with a serious disease in the ICU. So since we collected all of this data from the literature, the definition was theoretical and based on what we thought, what we considered as immunosuppressed situations. Check the paper and you'll find the exact information. Any other question for the speakers, please? Everybody wants to leave like Dr. Vanderplas to drink a margarita, right? Doctor, please, yes, 5 more minutes, and then they'll move on to the summary and our conclusions. Vera. Nelson Garcia from Paraguay, Asunción. 80% of cases for the eradication of Helicobacter pylori, the S. boulardii, increase the response. But together with antimicrobial therapy, what scheme of therapy? There's a lot of variation, so would you say that works with any scheme? Well, the current standard is a triple plan. As I said a little later, but it's still insufficient. As I said before, it's still insufficient. We right now know the Graham's chart that tells us a plan to be successful in pylori has to have 90% eradication, but no plan reaches that. So we need to continue to think about it. The problem is that we are thinking of how to avoid a certain amount of damage produced by antibiotics, and we have devoted quite a good part of this day to think about that. And out of 3 antibiotics, including in that plan, there's even a plan with 5 antibiotics for 5 days with nearly 90% positive results. Well, the standard is a standard you must apply in your country, in your region, according to the antibiotic resistance, as you know, and that which might bring better or worse results for each of your treatment plans. However, in these works, in the classic triple plan, improvement of 71 to 80% eradication usually adverse effects improve considerably.
Adelante, doctor. Sí.
¿Puedo preguntar?
May I ask, Francisco Cabrera from Mexico.
Allá, Vera.
Oh, Vera. Yes, please, Vera.
No, perdón, es que con estas luces no se ve nada. Adelante, Vera.
Cuando existe diarrea provocada por
When diarrhea is caused by antibiotics, Saccharomyces boulardii or another, do you suspend antibiotics or do you continue with the antibiotic and with the S. boulardii?
Ivan, would you like to
Ivan?
please?
Well, I think that certainly for pediatrics, 9 times in 10 we do not prescribe antibiotics for the right indication. There is certainly an overuse. So whenever you think that your antibiotic was not necessary, you can certainly stop it. On the other side, there are certainly children who need antibiotic treatment, which you have a real proof of a bacterial infection, and then you need to go on with your antibiotic and add the probiotic to it. So you can only stop the antibiotic when your initial indication was wrong, which unfortunately is, I think, often the case.
Ahora sí, Vera,
A
adelante.
continuación, mi pregunta es,
So my question is,
¿cuánto tiempo
how long
y la dosis
and
para
at
la
which
prevención
doses
de la
do you
diarrea
prevent
utilizando
diarrhea with
Saccharomyces
Saccharomyces boulardii, CNCMI 74.5?
Well, problem is the doses is I would say certainly for the prevention the same dosage as which is recommended for the treatment of acute gastroenteritis. In treatment of antibiotic-associated diarrhea in Clostridium in adults, higher dosages have been used, but in children, also in the Chinese study, it was the classic dosage as the same as in treatment of acute gastroenteritis. How long? Well, if you use it in prevention, I would say as long as you take the antibiotic, and in treatment, as long as the antibiotic is taken, and if the antibiotic is stopped, you do it for 5 days, 7 days, as you do for the acute gastroenteritis. That's what the studies designed that have been done. So treatment, as long as the antibiotic, or 1 week, and prevention as long as you take the antibiotic.
Eso porque hay
And
trabajos que
there are certain publications that tell us that they continue to use probiotics after they complete the antibiotic regime or scheme. So in your practice,
terminó el antibiótico
once they complete the use of antibiotics, they continue to use probiotics? Well, it's one thing to publish a work, state a protocol, and a different thing is your daily practice. No? Even if the studies are randomized and double-blind or whatever, what you do on a day-to-day basis is not always the same. What we do with our patients forces us to know evidence, right? So the fact is that a meta-analysis is made up of an endless number of patients. Sometimes some continued the use of probiotics up to 2 weeks later. Others use it for 3 days more, and the results were also good for them.
I think that the major difference between pediatrics and adults is that the role of Clostridium difficile in pediatrics is relatively very low compared to the adults, and that makes a huge difference in the therapeutic approach, where I think Clostridium difficile causing problems in children is in fact very rare, while you see it regularly in adults, and therefore the approach in adults might be different than in pediatrics.
¿Alguna otra pregunta, algún comentario? Sí, doctor. por
Any
allá.
other question? We have a doctor in the back.
En el centro acá.
Center in the back.
O allá, el que quiera.
Hola, sí, una pregunta.
We have a question. I have a question.
Hablamos de la diarrea aguda.
We talked about acute diarrhea, including
el uso de probióticos, en este caso con Saccharomyces
diarrhea with the use of probiotics in reducing the duration of the diarrhea. But is there a difference in the etiology? In Argentina and Latin America, rotavirus has an important load, but the normal virus in the US and in Europe has an even higher load. So this might make it different for us choosing the right probiotic according to the etiology. Any comments?
Dr. Van den Plas.
Most of in many studies with Saccharomyces boulardii, there were no stool cultures performed, so it's whatever infectious cause of the diarrhea. We all know that viral gastroenteritis is the most frequent. On the other side, there are, with Saccharomyces, specific studies in viral gastroenteritis showing efficacy in rota. There are specific studies in Salmonella gastroenteritis, in amoebiasis, and in other indications. So I think that both in the very specific studies looking at specific pathogens, or in general studies like in primary healthcare, you don't take stool cultures, you just see the patient, you treat them, that all these studies show that Saccharomyces boulardii works. So I would say it seems not to matter which pathogen is causing the diarrhea for this probiotic, while, as I showed this morning, for other probiotics, there might be a difference whether it's viral or bacterial.
¿Alguna otra pregunta, comentario de la audiencia?
Soy el doctor Cáceres de Honduras.
Dr. Cáceres from Honduras, and I have a question for Dr. Van der Plas and, of course, everybody on the stage. We know that S. boulardii has many uses on specific pathologies. It's very well documented. But I would like to know your opinion on some of the new probiotics in combination or the multiple strain ones. I think there are 7 probiotics in a single product. So what are your opinions on this? Well, I go back to what Dr. Ramirez said before. I totally agree. And we've all said it. Depending on what the studies what studies have been carried out, there are multi-probiotic that has been used, for instance, in pouchitis, or ulcerated colitis in children, particularly in a moderate or mild severity, with great efficacy. So probiotics in a single strain have not worked in those cases. On the other hand, to my knowledge, on diarrhea associated to antibiotics, I don't think that those multiple strain probiotics were useful. We always have to think. I would say, and please let me say this now that we're at it, the products that are for sale, some actually are not backed by a single study. There is no safety. No safety exists, no efficacy data. So what the doctor has to make sure of is to ask for efficacy and safety studies to the providers of a probiotic. Yeah, and I would like to add something like that. In the case of irritable intestine, the last meta-analysis was published last year, and they proposed that there is a possibility that a multiple strain probiotic might be more useful than a single strain one. But what Francisco said is very important. Many times when you consider these probiotics, in very, very small print says this has X number of colony-forming units at the time of manufacture. So when you use the product, nobody knows exactly the concentration of the dose. And almost all of them contain it. Just pay attention. At the time of manufacture. So I think it is essential for us to consider quality control, and quality control is essential in this kind of products.
Más uno, por favor.
Plus one.
¿Quién? Es que no se ve aquí. Adelante, doctor. Última pregunta.
So our last question, please.
Gracias. Sí, me ha quedado una duda porque cuando hicieron
I have a question because, this doubt, when you talked about the use of Saccharomyces boulardii in necrotizing enterocolitis in the newborn, after so many great presentations, I said yes when we voted. But then it turns out that the doctor said that one of the counterindications was when the child has a central venous catheter, and these children, all of them, have it because of their pathology. So what do we do? Do we give it, or in this case, it's absolutely no, contraindicated? That's the first reason why we can never use it in necrotizing enterocolitis, or maybe, no? Okay, let me tell you about Dr. Henneken's publication. He says that the possible role of catheters is due to manipulation, handling. Of course, everybody knows this. Handling and manipulation of dust near the patient, or even in other patients near the one being contaminated, might be the reason. And the recommendation at the end of that great review of 92 patients was to handle the line outside the place where the patient was hospitalized to reduce the risk. But in the case of newborns, nobody wants to bail the cat, as I said. Everybody creates their own experience. There are no recommendations, and we need to continue reading and find out what is next. Okay, we've come to the end. I ask the speakers to take their places because we angels have no backside, as you all know, but I am afraid of Cavani's revenge. Before finishing this, I would like to invite you to the Latin American Congress of the Pediatric Gastroenterology Association in Lima, Peru, from November 18 to November 21. Write it down because there is another one from the 14th to the 16th. It's not the same. It's not the same. Thank you very much.